Welcome, everybody, to the CHESS webinar, The Rapidly Changing Treatment Paradigm for Stage 3 Non-Small Cell Lung Cancer. I'm Gerard Silvestri. I'm a professor of medicine at the Medical University of South Carolina. Joining me today are Dr. Jessica Donington, Dr. Mariam Alexander, and Dr. Anurag Singh. Dr. Donington is from the University of Chicago. She's a professor of surgery. Dr. Alexander is an assistant professor of medicine at the Medical University of South Carolina. And Dr. Singh is at the Roswell Park Cancer Center in Buffalo. I'm really excited about talking through the myriad of changes that have occurred for stage 3 lung cancer, which include lots of different options for our patients. And we're going to review those options, the literature behind those options, and some practical ways to care for our patients with this stage of disease. I'm really pleased to have CHEST support us in this endeavor, as well as AstraZeneca, who sponsored this webinar. So I'm going to give you the outline. We're going to talk about the definitions of stage 3 disease, the emerging therapies in resectable non-small cell lung cancer, the challenges to biomarker testing in those with resectable disease, and the principles of radiation therapy for early stage non-small cell lung cancer. This next slide is really tells you just how complicated stage 3A disease is. It's 3A, 3B, and actually 3C. Mostly what we're talking about when we're discussing resectability and neoadjuvant or adjuvant therapy for that is really in the stage 3A range, with occasional patients in 3B sneaking in there. But I would point you to the fact that there's a lot of ways to get to stage 3A lung cancer. The commonest way is through patients who have ipsilateral mediastinal adenopathy, so level 2, level 4, on both sides, and level 7 in the subcarinal space. What's really changed in the staging system in the ninth edition of the staging system is now we've split N disease into N2A, which is single station lymph node disease. So, and then there's N2B, which you see in the upper right-hand side, where there's multiple stations in the mediastinum. Why is that important for pulmonologists? Because now, instead of just stopping our EBUS at one station, which is, for example, if you get a subcarinal positive lymph node, if you have other enlarged lymph nodes of more than 5 millimeters, you really have to go after that second station to make sure that you have both stations, which would make them N2B. In reality, it may make a difference, particularly in the future, as to what surgeons might want to operate on and what might they stay away from. So, for example, if you have multi-station or bulky N2B disease, they might not really be a candidate for resectability. The data on that's pretty soft right now, but I think clinical decisions are made sometimes on the extent of mediastinal disease. And then you can see stage 3B is generally contralateral lymphadenopathy, et cetera. So I'm going to stop right there. You can look at these slides at your will, but I think largely we're going to be talking about stage 3A, either single station or multi-station N2 disease. I'm going to turn it over to Dr. Donington, who's going to take us through her wonderful slides on what has happened really over the last 3 to 5 years. Dr. Donington?
Thank you. Thank you for the invitation and thanks for the slide deck. So this that we have demonstrated here are the Kaplan-Meier's from the most recent staging edition. It's actually from the ninth. And we can see that survival in 3A has really jumped quite well, up to 50%, which is really pretty impressive. But when we compare this to breast cancer and colon cancer, we really still have quite a long ways to go. It's also important to note that we're at the 20-year anniversary of the discovery of the EGFR gene in lung cancer. This came from Tom Lynch and the group at MGH, and it was quickly followed by this trial, the IPASS trial from Tony Mock. And what this trial showed was that if you had the right medicine in the right patient, we could see a result. So the EGFR targeted group on those slides is the green line. And for patients who had the mutation, this drug worked. And for those who don't, it was worthless. And so it was really the first time in lung cancer that we thought about personalized care for our patients. So now that was the very first 2005 when we saw that. And in the last 20 years, it has just been a whirlwind of discoveries on the medical oncology side with so many targeted therapies and immunotherapies. I would say over the same period, we've seen a lot of advancements in early stage disease. SBRT, minimally invasive surgery, screening, these things have all really benefited patients with the earliest stage of disease, but I think it's also put us in a really good place that now we can effectively take new medicines in stage 4 and move them into early stage disease. And that's what's been happening in the last 5 years. I think that's really important. And that's because better cures for locally advanced lung cancer, in my opinion, don't have that much to do with better local therapy. Because the reality is when I see someone and they're in my clinic and they have, nodal disease, while they may look like the person on the left side of your screen, the reality is three-quarters of them are that patient on the right side of the screen. And they have micrometastatic disease when we meet them. And all the good surgery and all the good radiation in the world is never going to make those cure rates better. So I really do believe that the next real wave of advancements in locally advanced lung cancer have to do with better systemic therapies. I
I'm
think this is
gonna
where I turn it over to the experts.
well, I am going to turn it over to one of the outstanding experts, Dr. Donington, who's going to take us through some of the background literature that helps inform us as to when and where to use targeted therapy in stage 3 lung cancer. Miriam?
So, we want to now go through some of the dramatic changes that have occurred in systemic therapy for early stage disease over the last 4 to 5 years. So, both targeted therapy and immunotherapy have changed the survival dramatically for metastatic disease. And we now have several approvals for both neoadjuvant and adjuvant immunotherapy for non oncogenic driven lung cancer, and also two approvals for oncogenic driven lung cancer. The first most important question to address after determining if the patient is resectable is to ask is if does this tumor have a targetable mutation before we consider if neoadjuvant immunotherapy is an option for them.
So, for patients who have a targeted mutation, there are two that are covered on a surgical front right now. And those are osimertinib for patients with EGFR mutations and alectinib for patients with ALK mutations. And that is based on these two really influential trials, ADURA and ALINA. So the ADURA trial was a large phase 3 trial worldwide that looked at completely resected patients with stage 1B through 3 lung cancer. And then patients were randomized to 3 years of osimertinib or placebo. The question of chemotherapy or no chemotherapy was not addressed in this trial, and about 60% of the patients had chemotherapy. All the patients had to have an EGFR mutation. This trial has now reported its 5-year overall survival, and adding osimertinib improved survival. It increased the risk of it decreased the risk of dying from lung cancer in half. That's pretty dramatic. All with the addition of 3 years of an oral agent. It's opened up a bunch of other questions, like is 3 years enough? And we still haven't answered what we do with chemo, but dramatically changed how we treat resected EGFR positive patients. The ALINA trial was somewhat similar, a completely resected stage 1B through 3 population, this time with an ALK mutation or rearrangement. This trial, they randomized between alectinib postoperatively for 3 years, I think, or chemotherapy. So no, so the chemo question a little bit answered. And here we've only seen event-free survival to date, but this really impressive improvement in event-free survival using the targeted agent instead of chemotherapy. So both of these have dramatically changed how we think about these patients and how we move forward with mutated patients. So we really do have very strong recommendations from all of our major societies. These are from the IASLC on using appropriately targeted agents in those patients who have mutations. So the first thing to keep in mind is that for patients being considered for surgery, who you might want to use an induction strategy or adjuvant therapy, that you have to do testing for EGFR and ALK as a minimum before starting treatment. And for those patients who do have an EGFR sensitizing mutation or an ALK alteration, they should not receive neoadjuvant chemoimmunotherapy or adjuvant immunotherapy because of we would much prefer that those patients go on to their targeted agent. Next slide.
I kind of just stop you there and make sure pulmonologists understand this, that we need to make sure that we're getting that biomarker testing and PDL1, even though it's considered, I think it's probably standard of care at this point for EGFR and ALK, because there is a difference between adjuvant, which is after surgery, and neoadjuvant, which is before surgery, and we want to know about those things. So for the pulmonologists on this call, we really would like you to get this at the time of diagnosis to get biomarker testing. So in a multidisciplinary setting, we can decide whether we just go straight to surgery and treat those patients with osimertinib or alectinib after surgery, or they get neoadjuvant chemoimmunotherapy followed by surgery.
Right.
Spo-
And the logic for these recommendations of adjuvant rather than neoadjuvant right now is based on several concepts. The concept that in the stage 4 setting, there's such an impressive benefit. The trials for adjuvant were so impressive, and that overall in the stage 4 population, we just don't see that same benefit with immunotherapy in mutated patients. So I think like I said, these recommendations go beyond the IASLC, but I think all of us who treat lung cancer feel like this is an essential concept moving forward, and one that's really dependent on good tissue.
Exactly.
So for those patients who don't carry an EGFR mutation or an ALK mutation, we still have a lot of options and a lot of trials which have reported out in the last 3 years. So we'll start by looking at the adjuvant space first. 3 trials in this space. The first one was Empower 010. This was a positive trial, but only in a select population. This was really positive, and we saw a benefit in those patients who had high PD-L1 expression. The next one that reported was Keynote 091, also positive, but in a different population. It wasn't positive when those were PD-L1 high, so that was very confusing. And then finally, this past year, we just saw BR31, same design as all the other ones, but this one used durvalumab instead, and it was a negative trial. I think these 3 trials that all had slightly different outcomes has really decreased some enthusiasm as immunotherapy as the first choice for 3A disease. Again, if someone goes into the OR as a stage 1 and comes out as a 3A, this is it. But if I knew upfront that a patient had 3A, I think we have less enthusiasm for adjuvant as we may have for the other approaches. Now, we only have one neoadjuvant trial. That was Checkmate 816. We first saw these results, I think, in 2021, the kind of tenfold improvement in path CR with 3 cycles of chemoimmunotherapy prior to resection. This was dramatic. This was a bit of a game changer. We then saw a dramatic event-free survival improvement with the addition of the immunotherapy. And next slide. And I think the most important thing that has come out of this trial was the very strong association between path CR and this is event-free survival. But just this last month, or is it 2 months ago at ASCO 2025, we saw the 5-year overall survival. And that association holds true also for overall survival. So again, if we can render the patient past CR with just 3 cycles of chemoimmunotherapy, chances are we have cured their lung cancer.
I'm going to stop right there and welcome Dr. Alexander back, who had some technical difficulties. Miriam, could you just comment on these series of trials and see if there's anything else within those trials that you'd like to state that Dr. Donington may or may not have covered?
Yeah, no, I was mainly focusing on the targetable mutations. I apologize that, my internet just cut out for a second, but, getting molecular testing is so important, as Dr. Donington said, just because it dramatically changes what the patients would get, right? They would not be in this neoadjuvant chemoimmunotherapy route, and that'll be a detriment to the patients who have EGFR and ALK mutations. But for this series of trials, it has changed the game for us. The cure rates, the PAT CR rate, all have been incredible.
I just want to ask one question to both of you, and either one can answer it. So in Europe, if the PD-L1 status is 1% or less, they don't recommend using immunotherapy in this group. Can you tell me what your feeling is about that? It's in terms of your confidence that if you have a higher PD-L1 expression, you're going to get a better result from immunotherapy, or how you guys approach that?
I can start with the adjuvant setting. I feel like things were a little bit clear with I think Dr. Donovan is going to go into the Empower 10 trials as well. And there wasn't as much benefit for the PDL1 zero. So in the adjuvant setting, I'm less enthusiastic if the PDL1 is zero. In the neoadjuvant setting, it's tougher. Yes, we are seeing better outcomes when the PDL1 is higher. So we're more enthusiastic about using it, but sometimes PDL1 can be a little bit heterogeneous. So it's where you get the biopsy from and things like that. So it's tough to not offer it to a patient in the neoadjuvant setting. At least for now, from the data that we have, it doesn't quite play a role in the neoadjuvant setting just yet. But
I totally agree.
Great. Glad to see you guys agreeing on stuff. Go ahead.
All right. So the next space is the periadjuvant, or sometimes I call it the sandwich space. And 5 trials reported out, and they're all incredibly similar in design. 4 cycles of chemotherapy plus immunotherapy, resection, and then pretty much in all of them about a year of single agent immunotherapy after resection. And the results from these trials, I would also say, are all very similar. So first we saw the Aegean trial with a hazard ratio of 0.65 or so on event-free survival. Neotorch, checkmate 717. Next slide. Rationale 315. This was out of China. But the king in the space has really been Keynote 671. Why? Do I think it's totally better agent that works 100% better? No, because they designed a different trial slightly, and they designed a trial for overall survival, and they found it, on their first look. So these medicines work, and this worked really well. Next slide.
Before we get to that, I just want to again point out for pulmonologists that what we're looking at here now is a year's worth of immunotherapy after treatment, right? And so pulmonologists need to be aware, and I know their oncology colleagues will inform them of this, that immunotherapy-induced pneumonitis is a real risk, and they are going to have to keep an eye on these patients for much longer. And I know Dr. Singh will go into some of that later on.
So now we're going to try and just kind of run through these and talk about how they're actually, I think, more similar than different, these trials. And I think that's good because I think we've, already validated our trials without having to redo that again. Next slide. So this is a big fancy table, but it's just so that, again, these trials are more similar than they are different. So next slide. These are all very large randomized trials. The smallest trial in here is 358 patients, and we have trials well over 1,000. They all paired a single agent PD-PDL1 with platinum-based chemotherapy. The only ones that didn't were Keynote 091 and BR31. They encouraged it, but they didn't require it. And those trials were not positive. So again, or not strongly positive, so maybe not a ways to go. As Dr. Silvestri just said, all of these trials are a lot of treatment, a year or more. The standout here is Checkmate 816. 3 doses done and dusted on that trial. They all included the same exact patient group. The staging system changed as these trials accrued, but the patients didn't. One, kind of those node negative tumors greater than 4 centimeters up to 3B. They all included stage 2 and stage 3 patients, and they all pretty much use a recurrence-based endpoint, that DFS, EFS, and the only standout here, next slide again, was the Keynote 671, the only one that said we're going to look first at overall survival. They're all a little different too in how they manage EGFR and ALK, and that is because our understanding of EGFR and ALK changed as these trials were conducted. We originally did include them in some of the earliest trials, but as we saw Adura and Alina report out, patients were then excluded from these trials, and they'll probably never be included again. Important thing, all of these trials were agnostic to PD-L1 expression for inclusion, and for the neoadjuvant, also for their overall survival endpoints. So again, PD-L1 negative patients were included, positive patients, high, low, that didn't matter. So these are the pathologic responses for the neoadjuvant and periadjuvant trials. And again, every trial, a tenfold improvement over chemotherapy alone in past CR and very similar responses in major pathologic response. So Dr. Silvestri hinted a little earlier, what does the impact of PD-L1 expression? It's our only biomarker really in this space. Other things like TMB haven't really panned out. Should we be using it to decide who gets this therapy or not? So as we stated, in the adjuvant setting, it seems to matter. So Empower 010 is the only trial in the adjuvant space that has given us 5-year overall survival data that came out of ASCO last year. And while it does seem to be quite an effective medicine in those patients who are PD-L1 high, in the overall intention to treat population that included PD-L1 negative patients, the trial wasn't positive. So I do think that this is a place in the adjuvant space where that really matters. And as we talked about, approvals around the world vary based upon PD-L1 expression. But what about the neoadjuvant setting or the periadjuvant? And here I think the question's not as valid. So one problem is that all these trials were agnostic, which meaning when you start to go to those subgroups that weren't pre-specified, sometimes there's just not enough patients to adequately answer this question. So this meta-analysis kind of pulled all those big trials that we've already talked about together and let us look at the results that way. So here we can see event-free survival by PD-L1 expression. And so again, the overall is positive, but when you look at the PD-L1 negative patients, the PD-L1 low patients, and the PD-L1 high, when you get a big enough group, we see that there is a good effect in every single one of those populations. Is it better in the PD-L1 high? Yes. That's why we get super enthusiastic about those patients who have a 90% PD-L1 expression. But it doesn't mean I don't think of this approach in those patients who are PD-L1 negative, because I still see a benefit in this larger group. So why is this hard, and why are there challenges to biomarker testing in this population? Well, it's just more work, plain and simple. Surgical workup used to be entirely about staging with CT, PET, brain MRI, and a physiologic evaluation. Now I need to add one more. It sounds like one more step, but it's actually multiple steps to get my biomarker testing. And again, EGFR and ALK are the bare minimum in moving forward, but things like PD-L1 has become very common, and many of us end up with next generation sequencing at a baseline. So this unfortunately means, again, another step where we may not have had to send someone to a pulmonologist for EBUS, but now almost everyone will need it. But even that is that there's that step afterwards where it's not just a diagnosis, but the staining for NGS or going out for those type of analysis and then back to tumor board for a discussion. More work. So I always say, that surgeons don't like extra steps and we like everything quick and efficient. And I save time on my OR schedule on Thursday and Friday for new patients. Next slide. And again, that means if I operate on Friday, my patients are home before Monday. It's been 6 days. They're done. I don't have to think about them until they come back for their post-op visit in 2 weeks. Now, if everybody needs a biopsy and everyone needs next generation sequencing and then to come back and see me, next slide, in my institution, that takes 1 month. I send them from my clinic to my pulmonologist clinic, and it still takes 1 month. And I have yet to meet an institution where it's shorter than that. And then if we're going to treat them, next slide, it's another 3 months before I see them again, or I'm ready to operate on them. That's a lot more work. It's a lot more steps. It's a lot more places where someone can fall through the cracks and we lose them. This is hard. And there are all these problems along the way. Is this gonna be we're gonna find a mutation we have an agent for? Is it paid for? Is the tissue from the biopsy enough? We already talked around turnaround time. The communication is continuous. It's just a lot more work. And I think outside the university, some of these hurdles are really, really challenging. But I think we need to admit that one problem with lung cancer in the past was that we thought it was one size fits all and we could treat everybody the same way. And that's just not how we cure cancer going forward. So, the last time we integrated systemic therapy into lung cancer was in 2005. And I would say the results at a 5% improvement in survival were okay. But since 2005, we have a bevy of new agents. But we also need better selection. None of these work in everybody. And so we need to use them in the right population. Luckily, we have better surgery. So I think we're ready to do this safely. And the hope is that we're going to end up with much better results for our patients with locally advanced disease. I can't say enough about the importance of tumor boards now. My tumor board, we almost meet twice a week now because there's so much to discuss. There are so many patients that go back and forth amongst all of us. And I think that, having this, infrastructure and place where communication can happen and making sure that patients don't get dropped is really essential now. This is a team sport and we need to treat it as such and kind of set up the ways that we can all communicate regularly. So the evidence in, resectable lung cancer is really impressive for the benefit with perioperative immunotherapies and targeted and TKIs in resectable lung cancer. Um, but it's really, really dependent upon finding the correct patient. These two tracks are mutually exclusive, and we've got to get the patient on the right track, or all the benefit of this new medicine isn't going to do them any good. So biomarker analysis has really become absolutely essential for stage 3 patients, and it's going to be that way going forward.
Well, thank you. That's awesome. And we're going to switch gears now to Dr. Anurag Singh, who's going to talk to us about radiation therapy. One thing I failed to mention at the beginning of the webinar is that you can put questions in the chat and in the question and answer box, and we will collate those questions and try to answer as many as we can at the end of this program. Dr. Singh.
Thanks, Gerard. I wanted to talk a little bit about radiation therapy for stage 3 lung cancer and how it has changed over time. So, in the old days, we'd get a two-dimensional image, we'd get a wax crayon, we'd draw the field, you'd be done and dusted in 30 seconds or less. In uh, in the more recent times, we've gone to three-dimensional data sets, and we were able to use those to target the radiation. And now you weren't stuck with just coming in at orthogonal angles mostly. You were able to come in at any angle and shape the beam directly to where the tumor fell in that. And now, in the present time, we're able to do intensity modulated radiation therapy. Now, this is a completely different animal. Here, we take the three-dimensional data set, we draw out the tumor and the normal tissues at risk, and let the computer shoot millions of beams in silico, so in the computer, in the computer itself, and figure out what is the optimal dose distribution. So there's no way to manually recreate what's occurring, and what you have to do is you just have to take what the computer did, run it in real life in a phantom, make sure that they line up, and then you can go ahead and treat the patient. But this gives you the ultimate ability to get conformal radiation around the tumor and minimize the dose as it goes away from the tumor. That comes at the cost of spraying low dose around, and you'll see potential impacts of that later. So, as Dr. Donington was saying, we also had to figure out how to intercalate our treatment with chemotherapy. And so We looked at sequential chemoradiation, versus radiation alone. Sequential was better. Then we looked at concurrent versus sequential, which is this study. And you see that there's a benefit to doing concurrent chemoradiation together, again, platinum based. Then next we asked, well, what if we've got all this newfangled technology? What if we increase the radiation dose, right? And what we found was that's actually a bad idea. And increasing the radiation dose decreased the survival in these stage 3 patients. Now, we've done further analyses and we showed that maybe with IMRT, this doesn't occur and we're able to spare the heart and other organs better. And so research is ongoing to try to figure out what are the sensitive normal tissues. But for right now, 60 gray is still king for chemoradiation in stage 3 lung cancer. So this is where we got to talk about the toxicities of radiation therapy. So let's take the standard group from that study, and 77% of them will have grade 3 plus toxicities. If we look at just the thoracic toxicities, the dysphagia, the esophagitis, and then of particular interest to this group, dyspnea, pneumonitis, and pulmonary bleeding, about 30% will have that. As we're thinking about the toxicities and how do we minimize them using IMRT, I told you that, we're getting the computer involved, we're shooting millions of beams. It's really too complicated for any one person to be able to track all of those variables. And so what we do is we create a table like this that says, okay, this is what the tumor is getting, this is what the lungs are getting, this is what the esophagus is getting, and all of the normal tissues, and say, does it meet the constraints that we found lead to toxicity? And if all those arrows are, if all those check boxes are green, then you can go ahead, and that's the quality assurance that we do. But it's very important that you understand when you refer a patient that this is the type of quality assurance that's being done at the facility where you're sending them, because it's not always the case. Yeah.
And I think we're going to turn this back over to Dr. Alexander, who's going to speak to us about unresectable treatment with without a targeted agent. So, Dr. Alexander?
So, even though we hope that patients proceed, with this multidisciplinary evaluation and surgery, a significant portion of our patients don't actually make it to surgery or are not surgical candidates. So, for unresectable non-small cell lung cancer, we have the pivotal Pacific clinical trial. So this trial randomized patients to the immunotherapy, durvalumab versus placebo after completion of concurrent chemoradiation. The updated 5-year survival showed a benefit of 47.5 months with durvalumab versus 29.1 months with placebo, which is quite tremendous. And when you break it down by PDL1, again, we see a much higher benefit with PDL1 high compared to the next slide showing PDL1 0%. So we know that PDL1 low tumors don't benefit as much from consolidation immunotherapy. For EGFR mutated lung cancer, so as a reminder that these patients don't traditionally respond to immunotherapy, we have the LAURA clinical trial, which randomized patients to osimertinib, so the TKI osimertinib, versus placebo after completing concurrent chemo-RT. This shows another successful trial with the PFS being 39.1 months, the median PFS, 39.1 months versus 5.6 months with placebo. So this therapy is also approved.
I'm going to stop right there and just point out to pulmonologists again, if you're the patient who has an EGFR mutation and no one knows about it, you're going to end up in that blue frame there. And honestly, I think pulmonologists and some surgeons, we've been a little bit over the years nihilistic about some of the presentations from our oncology colleagues, which show like, those two Kaplan-Meier curves close together, and then with maybe a 2.3 month survival benefit. But honestly, you could drive a truck through these Kaplan-Meier curves, and it's critical for my colleagues in pulmonary to understand that if you don't check for EGFR, your patient doesn't get to hit that home run ball. And we have numbers of patients now that have metastatic lung that are EGFR positive that are out 5 years and still doing pretty well. So I just want to just stop to make us realize how far we've come. And these kind of survival curves are just incredible. But you have to test for that EGFR inhibitor, even EGFR mutation to get osimertinib, which is a second generation TKI inhibitor.
So some of these immunotherapies and even some targeted therapies like osimertinib can cause pneumonitis. So that is usually where we turn to our pulmonary colleagues for a lot of guidance. So I'll go through some characteristics of immunotherapy-related pneumonitis, and then Dr. Singh will go through some of the radiation pneumonitis characteristics. So for immune-mediated pneumonitis, the timing can be quite variable, less than a month to any time in the course of disease. Having a pre-existing autoimmune disease and ILDs are risk factors, and it most commonly presents bilaterally with the absence of sharp borders. Much higher doses of steroids are required to control this compared to radiation pneumonitis. And then on the right, there'll be some pictures that come up that show that there's different characteristics on imaging. So panel A shows a hypersensitivity pneumonia-like pattern. The panel B shows a non-specific interstitial pneumonia-like pattern. C shows acute interstitial pneumonia-like pattern, and D organizing pneumonia-like pattern. So, quite variable and tough to diagnose. So now I'll turn it over to Dr. Singh to discuss the radiation pneumonitis.
Before we get to you, Anu, I just want to talk through to my pulmonologist when you get these referrals. It was at the beginning of the immunotherapy period that we did bronchoscopy on a lot of these patients. And whenever I see an abnormal CT during the treatment of a patient with lung cancer, it used to be, and still is, that I think about 3 or 4 different things. One, in patients with a clear chest x-ray, I think about thromboembolic disease because we know that patients with cancer have a much higher incidence of that. 2, I think about infection, although with immunotherapy, you don't normally see infections. These patients aren't getting neutropenic. The third is lymphangitic carcinomatosis, and there are some classic findings of that, and that may warrant a bronchoscopy if you're unsure. And then the fourth, of course, is this drug-induced pneumonitis, and you've seen the patterns explained by Dr. Alexander. We generally, with these, stop the drug, and then we, based on the findings and the symptoms, if they're very dyspneic and if they're completely asymptomatic, we may even continue the drug with very mild changes. If they have significant dyspnea, cough, low-grade fever, we're putting those patients on steroids. Now, sometimes I'll see them back in a month, and if everything cleared up, we would rapidly taper their steroid. Although other patients, it's a very slow taper and never reintroducing the drug. And there are some patients, sadly, that have a great response to their cancer that march through steroids and die of sort of an AIP, acute interstitial pneumonia, and we've seen that as well. So it needs to be taken seriously, and I like our pulmonary colleagues to help our oncologists manage that portion of the drug-induced pneumonitis. So, and I'll turn it back over now to Dr. Singh.
Thank you very much. As has been described, if you see a hazy area in the area where the tumor was, well, then that was just radiation being successful. If you see, this cryptogenic organizing pneumonia pattern, as you see on the left, in a 63-year-old patient who presented with a wheeze, that responded to steroid therapy. The nonspecific interstitial pneumonia pattern that you see here, this patient was treated with 3D CRT, presented with cough and shortness of breath that again responded to steroid therapy. And then getting to Dr. Silvestri's point, the AIP picture on the right, that patient was treated with IMRT and needed hospitalization for worsening hypoxia and died 2 weeks later. Now, I don't know what the follow-up was in that particular case, but in my patients where we've had this rare event and there weren't other drugs that we could blame for it, it turns out that it was viral associated in several instances. So that would be another thing to consider if you've got this kind of presentation. So we've talked about chemoradiation and durvalumab. So if some is good, right? So some durvalumab after chemoradiation, then is more better. That was the Pacific 2 question, where they were adding neoadjuvant, concurrent, and adjuvant. And the Pacific phase 3 trial did not achieve statistical significance for the primary endpoint of either progression-free survival or anything else. Now, one thing that needs to be in considered is that, it was 2-to-1 randomization in both the Pacific trial and the Pacific 2 trial. And when you believe that your treatment is effective, that is a very rational thing to do, but it comes at the cost of making the estimate of the placebo group more prone to error, right? And so the Pacific trial, the placebo patients did much worse than would be expected in the modern era. And again, it's hard to argue with phase 3 results. They were all treated the same, but it is something to keep in mind. And there was an increased rate of infection observed during during the concurrent treatment period in the experimental arm. So when you're adding the things together, they may behave differently than when you're just doing it adjuvantly or neoadjuvantly. And when you look at immunotherapy and radiation, thankfully, again, in the adjuvant setting, not a lot of change, maybe pneumonitis with a certain drug, but there's the increased infection, and the other drugs, thankfully, have been mostly tolerable or no change when you've added them together. But you've got to keep it in mind all the time. And you've got your other targeted agents, and thankfully, many of them don't have significant problems. But then I will take you to the alectinib, where there was a case of radiation-induced CNS necrosis, with one case happening 12 months after alectinib and 7 years after the original radiation. Okay. So that is definitely something that keeps me up at night. And when you're trying novel therapies, there's always the possibility of novel toxicities that you need to keep in mind. And then with bevacizumab, we know that there's pneumonitis risk, pulmonary hemorrhage risk, and tracheoesophageal fistula risk. And thankfully, this is not something that we commonly use in stage 3 disease.
So I'm gonna finish up here and then open it to our audience for questions. But what I'd like to say is, look, stage 3 management's become more refined, and I think you've seen that. And sometimes I think pulmonologists need to see some of this evidence. And I'm so grateful to our participants for showing you the evidence that immunotherapy and targeted molecular therapy in both the neoadjuvant, adjuvant, and unresectable settings works, and it works really well. But it requires us as pulmonologists to be part of that team that Dr. Donnington spoke about, and make sure we're up to date on some of these new treatments, and understand that it's our role as the first line in that clinical journey, where we have to get tissue, and we have to get enough tissue to get biomarker testing done in a quick manner. Immunotherapy and targeted therapy has improved prognosis significantly. Surgical and radiotherapy advancements really have enhanced our patient outcomes, and we're seeing much, much longer survivorship in our patient population. And the multidisciplinary team that includes radiology, pulmonary, surgery, pathology, med-onc, and rad-onc is crucial. And I would add clinical trials, and I would add the nurse navigator as really the linchpin of working our tumor boards out. And so with that, I am going to stop. There are some references here. I'll take you through them slowly. And with that, I'd like to say thank you to the folks at AstraZeneca for supporting this. And let's open it up to questions.
So we do have 2 questions. The
Okay, go
first
ahead.
is, Does it matter if the molecular testing is done from tissue or blood liquid biopsy?
Mary, why don't you take that on, and then we can all throw in our opinions on that.
Yeah. So yes, for this early stage disease, and even for metastatic disease, in both cases, it does matter. Especially for the early stage disease, we don't know, how much tumor is shed, into the system. So what we are worried about here is having a false negative result. So that's my concern. Their ctDNA technology is getting so advanced that we will probably get to this point, where we are going to be able to detect. But right this minute, I worry that it's going to be a false negative. So things to consider here is, what is some of the characteristics of your patient? Is it are they never smokers or light smokers, adenocarcinoma? So it might be important to even consider another biopsy if they meet some of those characteristics.
Just Anu, do you have anything to add?
I completely agree. I don't think the technology's there yet. I think a positive is great. And sometimes when we're really anxious to get treatment started, we will draw a ctDNA at the same time that we're doing their EBIS because they typically come back much faster. But what if you don't have that positive, it doesn't mean anything. A negative is I agree, completely worthless. And all those trials that I talked about, they all had a ctDNA component and none of them found it in all their patients. It's much more like kind of 60% at the most, even though we know all these patients had, stage 2 or 3 disease.
Yeah, we did a trial recently that's under review at a journal now, a three-site trial, Ohio State, MUSC, and Hopkins, where we did simultaneous EBIS with the liquid biopsy. And the interesting thing there, and I'd love to have everyone's opinion on this, is if it was much more likely to be positive for mutation in the tissue. Yes, that was true. But there were times that was negative in tissue and positive in blood. And also there were a few times where it picked up an unusual, now not something we have a target for, in blood that was not in tissue. So there has been a little trend, particularly among academics, for kind of ordering both at the same time. I mean, that might not get covered by insurance, but let's leave that part of it alone for a second. Is that something that you see as a trend, and is it something you'd think about, especially in light of trying to save time? So I think they're complementary. That's my results from that trial, by the way, is I think they might be complementary.
I think it's a good approach. I think unfortunately we're ignoring that fact that they might not all get paid for. And that's a little hard. But I agree. And until our tissue gets faster and our tissue is so slow, we are really challenged to get people started. And it's hard to tell someone when we sit in clinic, which I often now do with these stage 3 patients, that we are not starting treatment for a month. And I have to set the expectation that that's not happening. And that's sometimes really challenging for patients to accept.
Yeah, and there are ways to shorten that time. One is reflex testing, which we're not going to have time to get into, but the longest time in that whole period of turnaround time for biomarkers is between when the tissue is acquired by a pulmonologist or radiologist, interventional radiology, and the order is placed. And oftentimes the patients wait until they get to the oncologist, and then the oncologist is saying, "Oh, now I got to place the order," and that is another 2 weeks. So that turnaround time could be shortened if we had some reflex testing. And Anu, can you keep asking questions then?
Yes, sir. Next question is lung cancer causing agent. So smoking or genetic factors, does that impact this discussion?
Mary, you want to take the first shot at that, and I'll take a quick view of it?
I think, Gerard, I feel like you would handle this one better.
Yeah, so we know that smoking is 85 to 90% of all lung cancers. I wonder if the question revolves around, are they more likely to have a targeted mutation if they're a non-smoker? And so there are these groups like Asian female never smokers that have a higher incidence of EGFR positive and mutations. However, that doesn't preclude finding those mutations in a smoking population. And so this idea that maybe we should just test those certain groups and not other groups, it doesn't hold. 17% of a North American, by and large, North American population will have a mutation of EGFR, and that might vary in your city or town, but overall, we're seeing these mutations. And if you look at all mutations, EGFR, ALK, BRAF, and others, it's now up to about 35 or 40%. If you add a high PD-L1, you're over 50% will have some type of actionable mutation that you can look for. So for me, in terms of the genetics of it all, we know that lung cancer, a family history of lung cancer, increases your risk of lung cancer, irrespective of smoking history. But to me, like, we test everybody that comes through the door now, right? We test everybody, particularly with stage 3 disease.
Yeah, and I would just put in one brief pitch that smoking is still bad for you. So when you get these patients, if they are still smoking, their survival will increase if you can get them to stop. And so we've seen that. At Roswell Park 10 years ago, there's a recent paper in JAMA Oncology from MD Anderson and Graham Warren that showed that that is still the case. That getting patients who are just diagnosed to stop smoking within the first 5 years of their diagnosis makes a significant impact. All right, next question. What is enough tissue for EBUS?
Yeah. So there's never enough. But what I would say is this: we have a paper years ago that said 3 passes, 3 biopsies of a lymph node was good enough. After 3 passes, the diagnosis, not molecular, but the diagnosis of lung cancer didn't improve. You had 90+%, 95% chance of diagnosing cancer if you did 3 passes in a lymph node. We know now that that's not enough. And so there was a meta-analysis that showed that to get up to that 95%, be able to run next generation sequencing, it needs 6 passes. Now, does it always need 6 passes? If you have rapid outside evaluation or rows in your bronchoscopy lab, and you have a very good cytopathologist sitting there saying, Gerard, you got sheets of cells, you don't have to have 6 passes. But if you don't have that type of support, and the patient's quiet on the table, I would do 6 passes. And we surveyed pulmonologists, 450 pulmonologists. Adam Fox in our lab published this in Chest, and it showed that 10% of the time our pulmonologists are doing 0 to 2 passes. To me, that's a drive-by EBUS. It's not like an EBUS. And our interventional, when we broke it down by the type of pulmonologist, our interventional pulmonologists were taking 7 or more passes. So the more the better, and I think at least 6 passes to get good molecular testing and PD-L1.
All right, so we have another question that's along the same lines, but marries something that Dr. Donington was saying, that she's got to talk to patients and say, hey, it's going to be 4 weeks. So, Dr. Donington, that patient, but they're coming to you from an outside facility, okay? And they've had the diagnosis. So they've already had to wait, what, 12, 13 weeks to see you because you're busy and you're famous and all.
3 days to see me. You call me, I see you in 3 days.
I can attest to that. I've sent people to her.
Um, so, um, so they have potentially inadequate tissue. So they only got 3 passes. They didn't get 6, right? Would you consider proceeding with what you have, or do you delay for proper tissue acquisitions and sampling?
So we do tend to rebiopsy. It obviously depends on the patient, the situation, the risk, but we kind of live by this, and that we think it's worth rebiopsying a patient if we don't have enough for moleculars. We just need enough for that EGFR and ALK. I will kind of argue against sending for next generation sequencing, or at least waiting for it. But if I don't have an EGFR and ALK, I do feel like I'm doing this patient a disservice. I just don't know how to treat them. And like, as I stated earlier, in stage 3, I really want to give them neoadjuvant chemoimmunotherapy. That's my goal, but I don't want to give it to the wrong patient.
Totally agree. And with that, we're really coming up against the clock here, and I want to thank Dr. Singh, Dr. Alexander, Dr. Donington. You guys are amazing. Appreciate your help and input, and I hope that the people online enjoyed this talk. I want to thank Chest one more time and AstraZeneca for supporting this, and I think we will end the webinar here. Thank you guys very much.
Thank you.
Thank you.
Thanks, everybody.